can we start with today's session? Hearty good afternoon to all. Welcome to our fourth session. Today we are having a topic on delirium and agitation. It will be taken by Dr. SHOBA. So we can start with ma'am's presentation and have our discussion around after that. Over to Sunil, sir.
Thank you, Rajalakshmi. Welcome you all to this fourth session on this COVID series. Today's topic is delirium and agitation, which will be taken by Dr. SHOBA Nair. Dr. SHOBA has done her MBBS and MD from Kerala and has done MRCP from Edinburgh. Currently, she is doing her PhD in palliative care and working as a professor of Pain and Palliative Medicine at Amrita Institute of Medical Sciences. Welcome you, Dr. SHOBA, and it's over to you.
Thank you, Sunil. Good afternoon, everyone. If I'm not audible, if you're not able to hear me, please interrupt. Otherwise, I would like to place and record. Thank you to the ECHO team at Delirium, Rajgopal sir, Rajalakshmi, and Vishnu, if I'm right, if I've got the names right, and Smriti as well. So yesterday we discussed about breathlessness, and I think the symptoms in these patients are kind of it's like a continuous saga. So you can't actually differentiate between one from the other, because breathlessness leads to anxiety and agitation and delirium because of hypoxia that can manifest later. Okay, so we're going to talk about delirium and agitation. So what are the learning objectives of this session? To identify agitation with delirium, without delirium, management of both, and any other effective management techniques that you can suggest. So imagine a patient, a COVID-19 patient is coming to the hospital. He's been quarantined at home, and he has mild fever. I think when we have fever, we are supposed to go in for a test, but until the test comes, maybe we are still quarantining at home. So as soon as the test becomes positive, you either come to a secondary or a tertiary care center, as is the case in Kerala. And
Dr. SHOBA, 1 second. Dr. Veena, you were talking something, ma'am?
Sound is less. Volume should be increased a little bit.
Okay. I think maximum. Should I speak a bit loudly?
I think volume is okay. Please increase the volume of your system.
Maybe if you could use a headphone, because it's coming like you're speaking in a hall. It's kind of, the resounding the voice.
Right. Okay. So I need to go on. That will take some time.
That's all right. That's all right. Maybe.
Yeah. If I speak loudly, is this okay?
Yeah, this is better. You're nearer the.
Okay, I'll probably lean forward and then speak. Yeah. Okay. So when a patient comes to the hospital, he or she gets examined by the healthcare team in a busy admissions area, and there's mild anxiety present. So what are the contributing factors for this anxiety? First of all, the patient is away from family. The patient is coming alone, worried about what's in store next. The patient might have dyspnea. And then the dyspnea worsens, there's hypoxia. Then the patient becomes restless and anxious, more anxious, but the patient is oriented. Okay. So now this is one point where we can intervene, where the patient is restless, anxious, and mildly agitated, but oriented. Later on, the patient becomes disoriented, which can lead to agitation and violence next. Sometimes that can happen. I don't know about the graph in COVID-19 patients, but then they become too hypoxic and they're probably not able to respond, and they become agitated before they go into that state. So in a clinical scenario like this, there are two instances at which you can intervene. One is when the patient is oriented, another one when the patient is disoriented. So let's see what we can do. But before we get into that, we need to assess delirium. And is it possible in a very busy kind of a setup where a lot of patients are coming in. I hope that doesn't happen in our country. But in case that happens, how can we assess delirium quickly? You know, there are umpteen scales in the literature, which is used for screening, which is used for uh, diagnosis and the diagnosing also the severity of delirium. So we don't have time to go into all the details of these intricate tools. But there is one tool that maybe we can use quickly, which can be used by anyone if they're inclined to. But otherwise, you can just say, okay, this patient looks delirious or is not oriented, is drowsy. So what do we do next? But let's look at this tool, which is useful, which is called the 480 Delirium Assessment Tool. I'm sure you're aware of this tool, but let's go through this. We'll take some time for this. Usually used in patients who are 65 and above, but is very useful in other patients as well, as what I understood from my literature search. The 4 A's in this is alertness, AMT4, attention, and acute change. I'll come to each one right now. So alertness, obviously, whether the patient is alert or not, mild sleepiness for less than 10 seconds after waking, then becomes normal, and clearly abnormal. One second, just hold on. So can you hear me?
Yes, ma'am, we can.
Okay, so alertness, and then comes AMT4, where it is the abbreviated mental test 4, in which you ask 4 questions: age, date of birth, name of the hospital building, and the current year, which you normally ask a patient who would come and seek medical care. Okay, no mistake 0, 1 mistake 1, and 2 or more mistakes or untestable 2. Now, third one is attention. Ask your patient to list the months of the year backwards. I don't know whether this is going to be possible in an acute kind of scenario like breathless COVID-19 patients, but is there for us to assess. In fact, this attention part of it is a single point assessment that can be done for patients to determine cognitive impairment, is what we could say. Okay, so 7 months or more correctly 0, starts but scores less than 7 months, refuses to start is 1, untestable is 2, and then acute changes or fluctuating course. Evidence of significant change or fluctuation in alertness, cognition, other mental function arising over the last 2 weeks, and still evident in the last 24 hours. Now, there's no one to tell you this with the patient, whether there's any change in the past 2 weeks on the last 24 hours. This will be very difficult for us to assess. And for this reason, the information will be incomplete when we use this particular tool. But it's the simplest tool available, which can be applied quickly. If somebody leaves them where they like this, or you can probably call the relatives and ask them. That would be a better plan. So 4 or above, possible delirium, use the delirium pathway. 1 to 3, possible cognitive impairment. 0, delirium or severe cognitive impairment, unlikely. But delirium is still possible if 4 information is incomplete, which is acute change of fluctuating course. So this is a very rapid tool which anybody can use. Nobody needs to get trained in this. So what is the evidence for management of agitation, delirium in COVID-19 patients? Do we have any evidence so far? We don't at the moment have any evidence, but there are a lot of guidelines which have come out. Raju Balsa was talking about NICE guidelines yesterday. It was a very useful guideline in which different symptoms are given in detail, which can be managed. And then we have guidelines from Germany, which Moira Lang had sent, which is very useful, very given very clearly. And they have all these guidelines are talking about assessing what is the cause for agitation. So we know that the patients are hypoxic, but what they're saying is don't roll out other causes and take it for granted. So we'll come to that in a minute. So NICE guidelines, German guidelines, then we have Center to Advance Palliative Care guidelines, in which again they've listed other causes for agitation and delirium. And they've also emphasized on NSAIDs contraindicated in COVID-19 when they kind of actually brought this guideline out, which is, I mean, just last week or so. Okay, so what are the factors that can contribute to agitation, anxiety, or delirium? Of course, breathlessness in these patients, and hypoxia, I have not written it there. So definitely, you need to give oxygen to these patients. Could the patient have pain? Obviously, because a lot of, if you listen to the patient narratives or read about patient narratives, which is widely available now, all of them seem to say they have myalgia, severe myalgia, or chest pain, breathing difficulty, and breathing causes pain in the lungs. So inspiratory pain or expiratory pain, that is not actually described, but what they're saying is it's like 1,000 needles into the lungs, and that's the sort of pain that they're explaining. So they have severe myalgia, they have pain while breathing. So breathlessness and pain could be managed with one single drug, which is morphine, which has been talked about yesterday and day before by Dr. Rajashree and Dr. Sunil. So that is one drug in the armory that we have, which can control anxiety also. Okay. So does the patient have urinary retention or constipation? Don't know whether it's a good idea to ask about constipation when the patient is actually acutely anxious, but probably you can, have that at the background. You need to check that. Have you passed urine? That sort of thing can be asked easily, and maybe the patient needs to get catheterized. But what we should not forget, especially in a state like Kerala, is the patient having any withdrawal syndrome? Because there have been incidences where doctors have been prescribing for withdrawal syndromes, alcohol prescriptions, which has been a little controversial, and I'm sure Dr. Raj Gopal will be able to talk about it more later on. So, is a patient having withdrawal syndrome? Should we control that withdrawal syndrome by giving chloride oxide or something else? If the patient is on narcotics and the supply is just stopped suddenly, then we might have to supplement with buprenorphine or morphine itself. The over-the-counter acquirement of tramadol, it is tougher now, but it's not impossible. And in our practice at Amrita, we keep seeing a lot of patients with non-malignant disease, getting over-the-counter prescription for tramadol. And we know that it is difficult. They don't get it without prescription now, but it's still easily accessible. So coming to the management, what are the non-pharmacological things that we can do to calm these patients down? I think that this is very valuable. Health care professionals should be calm, capable, and compassionate. Sometimes it's difficult for us to don this hat on when it's a kind of acute confusion, chaos. I hope it doesn't come to that level. And I think when Dr. Charu Singh presented the other day, she was talking about guidelines of triage, and Moira rightly highlighted that, and both of them said that responsiveness is a very important word. So responsiveness, it's like, when you see a patient, you're walking past a patient, when you see a patient on a stretcher or a trolley, it's always good to have an optimal response. Be calm and kind to that patient and say, I'll just come to you in a minute or so. Just let me get this sorted and I'll come back and I'll talk to you in a minute. That kind of a thing will give a lot of confidence for patients, as we all know. So start a gentle conversation, reassure the patient. In COVID-19 cases, I think reassurance, to what level is a question mark, but still it might be a little bit easier as far as palliative care physicians are concerned, because when we talk to cancer patients, it's extremely difficult for us to give a very positive picture, although we don't make them lose any hope. So reassurance in these patients might be a little better than our routine cancer patients, is what I personally feel. We can debate on that later. Keep the room airy and lighted as much as possible. Ask if they want to convey a message to their family, or if they want to talk to the family. And we were talking about, ICU patients or ward patients talking to their families through electronic media. Encourage them to ask any questions that they might have. So it's always good to talk to them and say that if you have any questions, please don't hesitate to ask us. And that gives them the reassurance that we are open to any of the concerns that they have, and we are there to help them. So that kind of a verbal and a non-verbal approach will help to calm the patient down to a certain extent. So in agitated and oriented patients who has anxiety, who's got panic, and maybe some amount of fear, what are the things that we can do, pharmacological interventions that we can do for this patient? So if it is mild and if the patient is able to swallow, you could try lorazepam 0.5 milligram to 1 milligram BD oral. BD is twice a day, oral or sublingual. Oral tablet can be used as sublingual. Now there is a lot of literature about patients opening their mouth and us giving sublingual, whether aerosol will be generated. It's not like interventions, but still whether the viral load will be high and it will be excreted in the air, because nose and mouth are supposed to be breeding place for this virus than other areas, as we all know. So, but still people say the amount of time the nurse has to spend near the patient is much less when compared to injections. If we are supposed to give a subcutaneous, if you're supposed to put a subcutaneous line, that will take much more time. But that doesn't mean that we're not going to do that. But if the patient is able to swallow and the symptoms are mild, we can give lorazepam. And clonazepam, again, it is a little more longer acting than lorazepam. And one of the uses for clonazepam is what we have found is, it is used for as an adjunct in pain relief, just like pregabalin or gabapentin. Clonazepam is used in Western countries for pain relief. So anxiety, it is used for a little bit of sedation. It helps the patient to sleep, and is also useful in pain. So clonazepam is a good choice, is what we feel. 0.25 milligram to 0.5 milligram twice a day. If not able to swallow, you could give injection midazolam, 2.5 to 5 milligram bolus injections, and SOS. So this is mild symptom in agitated and oriented person. In moderate symptoms, if the agitation persists, a continuous intravenous or subcutaneous infusion with 10 milligrams of midazolam in 24 hours can be started. You can keep on giving extra doses of SOS dose of midazolam depending on the physique of the patient. And if you're not confident in giving 2.5 milligram SOS at a time, you could still give 1 milligram, 2 milligrams, 1.5 milligram as you seem deemed right. So 10 milligram midazolam infusion in 24 hours can be started. If symptom persists after starting the above infusion, which is 10 milligram of midazolam, add injection haloperidol 0.5 milligram every 15 minutes SOS, or 1.5 milligram to 5 milligram in 24 hours. So first, when the patient is oriented, if the patient is agitated, restless, is sort of panicking, we could start with benzodiazepines, then add on an antipsychotic, which the normal thing that we add is haloperidol, which is easily available, which is cheap, and is available as injection. All right, so we'll talk about till moderate symptom in this, and then we'll go to somebody who's agitated and disoriented. Okay, and then this is classified as delirium. If it is mild, you can give injection haloperidol 1 milligram slow intravenous or subcutaneous, or I'm not able to see this, or 1.5 milligram per hour. It may be repeated every hour up to a dose of 5 milligram, oral as well as injectable. Or a bolus injection of 1 milligram haloperidol can be given intravenously or subcutaneously, and a continuous 5 milligram haloperidol can be started simultaneously. Okay, this is mild delirium. Then comes moderate delirium. So if agitation persists, so we have already started injection haloperidol, and if agitation persists, add injection midazolam to this, 1 milligram slow intravenous, subcutaneous, and repeat every 10 minutes till the patient becomes quiet. Or a bolus injection of 2 milligram midazolam can be given intravenously or subcutaneously, and a continuous infusion of injection midazolam 10 milligram can be started along with injection haloperidol. So either injection midazolam 1 milligram slow repeated injections, or a bolus injection can be given and a continuous infusion can be started along with injection haloperidol. So first haloperidol in delirium and then benzodiazepine. So intractable agitation in delirium, it is a common pathway. And some, as I said earlier, it might be very difficult to distinguish between just agitation if the patient is really little sleepy, drowsy, and things like that due to various other reasons that the patients might have. It becomes really difficult to differentiate between the two. It's always safer to start haloperidol before benzodiazepines. So if the symptoms persist, a maximum dose of injection haloperidol, 20 milligrams, injection midazolam, 30 milligrams can be given as a continuous infusion in 24 hours. I'm sure all palliative care physicians have experience in using midazolam up to 60 milligrams in 24 hours. But I think we have kind of kept it at a cautious level of midazolam 30 milligrams for these guidelines that we have produced together. So injection with haloperidol, injection with midazolam can be given as a single infusion. So these two drugs are compatible and can be loaded in one syringe driver if syringe drivers are available, or it can be, put into 100 ml and NS, and these injections can be put into that bottle and then run through infusion pumps. But you have to calculate the drops and then continue the infusion. So injection haloperidol 20 milligram, injection midazolam 30 milligram can be given in intractable agitation and delirium. So the summary is there might not be enough time to recognize agitation and delirium. 480 delirium assessment tool can be used quickly, but most often that's not going to happen. Remember to treat pain with paracetamol, morphine, etc. Remember to ask for possible withdrawal. Treat, and if you're not confident enough to look after these patients, refer appropriately. You might need a psychiatric input, general medicine input, and treat with chlorodiazepam, oxide, diazepam, or narcotics. The best thing that you can, if you confirm that the patient was abusing narcotics, you can immediately start the patient on buprenorphine. For anxiety and restlessness without disorientation, start a benzodiazepine. For restlessness, agitation with disorientation, start an antipsychotic. So take-home message would be correct the correctable, which is always the case, and treat agitation and delirium. If untreated, it can lead to cognitive impairment later, especially in geriatric population. It can lead to increased morbidity and mortality. Thank you.
Thank you, Dr. Sharma. Rajlakshmi, please unshare the screen. So the session is open for discussion. Anybody has any questions on this? Yes, Dr. Param.
Yeah, just wanted to make a small comment regarding delirium in these patients. So one of the important things we do in delirium management, which is the non-pharmacological, is that we try to have as much as familiar people around, family or friends. So the specific thing or a peculiar thing about COVID patients is whatever the in a situation we can't have their family around. So that could be a challenge in managing delirium in these patients. Like making the environment friendly is a very important non-pharmacological intervention which may be missing in these patients of COVID when they're being managed in ICU. So that could be a challenge.
Yes, thank you, Dr. Param. Yeah, that is one of the usual way of managing delirium, to have familiar people around. But in COVID, it is difficult and it has to be avoided. So thank you for that. Anybody else?
Totally agree.
it's not only the family. I think even the team will be changing, because we'll be having so many different schedules of duty. So the physicians and the nurses who are going to take care of, if there is an increased influx of patients at end of life care, I think even the staff who's going to take care of these people will be changing a lot. So that itself is, again, family also will not be there, and even the staff will not be that familiar.
Yeah, thank you, ma'am. Teacher.
Usually the challenge is most all those who are treating these patients, no, all will be in PPE.
Yes.
So this is not something our patients are exposed to. They always want to see the face of the doctor, feel the touch of the doctor. So this is not happening, and that's the biggest challenge in these situations. And even we during NIPA also, in fact, we were just writing it's doctor, nurse, like that, because patients were not getting whom they are talking. So it's like someone has come from moon. So that's a biggest challenge, and patients usually feel that itself causes a lot of agitation and restlessness because of where they are, why they are there, they try to understand.
That's absolutely right, Dr. Chandni. It's like, you can't even touch them, because our practice of medicine also is so different in these patients. So that's a real challenge, as you say.
Yes,
And
teacher.
the other ways we can tell them, if we are, this time I've not gone there, but during NIPA and all, when we go to the patient, we will tell them, I am Dr. Chandni, I will come here to see you, and those things we repeatedly we will tell them, so that we'll have some familiarization with the patient and the situation. And here also, most of the patients, even asymptomatic, we are keeping inside. So we need to have a clear explanation why we are keeping them inside the house. So there is a lot of impact. How do we address the issue why they are keeping inside alone? So this has to be clearly explained. That is one way, I feel.
If I may add something, uh, what I'm going to suggest is out of question in a very busy institution treating numerous patients with COVID-19. But if it is not, if there is somebody with any time, I wonder, the general principle is the more the unfamiliarity of the environment, the more the delirium, the more the agitation. And one of the things that we try to do in palliative care is to avoid hospitalization as much as possible. But if it becomes necessary, and if the caregiver is not a familiar person, one, to have as many objects that are familiar as possible. That also will not be like a clock on the wall that they are always seeing. This may be possible in a hospice, but not in a COVID treating facility. But translating that same principle, I was wondering if the family with the familiar voice could send some recordings, maybe recordings of reassurance. Papa, we are all here. We are waiting outside. We are here for you. We cannot come in now, but we are here for you. And that kind of message, I wonder if that will be helpful. But that's one thing. About the pharmacotherapy, because there are so many very experienced palliative care physicians in this group. Moira maybe with as many as 3 decades of experience. I have this dilemma when reading about COVID-19 and agitation. I know that in the context of intensive care units or GPs, the management meted out to delirium and agitation is often a benzodiazepine as a first line. But in palliative care, I've studied and seen also that not infrequently, benzodiazepines actually worsen the agitation as a first line drug, mind you. So the general principles that we have used is, apart from removing any causative factors, to use haloperidol as a first line medicine and use a benzodiazepine as an add-on. But when we look at the current Western guidelines on agitation, we find that the two that I have seen both are recommending benzodiazepines as a first line. So maybe we need to rethink about it. The guidelines we all know are not evidence-based, more of intuition rather than science. Therefore, should we fall back more on the palliative care experience and use haloperidol as a first-line medicine and benzodiazepine as an add-on?
Whether you want to add on to that?
Thank you so much. I think we're all in relatively new territory here. We all have our experience, some of us several decades, some different places and specialties. What I'm hearing from colleagues in Europe in particular, who are clearly in the middle of their pandemic peak, is that this is a symptom complex, just as SHOBA says, which is breathlessness and agitation. So I think if it's a delirium for, if you like, a more traditional reason, then of course we should be careful with early use of benzodiazepines. And I think, SHOBA, you were pointing that out. So we do need to try and think what is the cause of the agitation and the delirium. But I also think we need to be aware that there appears to be at the moment a symptom complex, a symptom cluster in end-stage COVID-19 patients, which is relating to air hunger and agitation. And in that circumstance, then a benzodiazepine and an opiate together would be the best approach to symptom management. And I think that's maybe the difference to our normal palliative care approach. This is really breathlessness with agitation and anxiety associated, but we need to make sure we don't miss out other forms of delirium and manage appropriately.
Thank you, Myra.
Yes, Dr. Param.
Just a continuation what Moira said. So, and Dr. Rajagopal. So I mean, as we've always used, the haloperidol remains the first line in agitated delirium. But maybe apart from the terminal air hunger, even the initial stages of COVID, because of so much of information and people before going into the hospital may be anxious without a delirium. I guess that is where they're using more of benzodiazepines, because in a clear-cut delirium, of course, we know that haloperidol works better than that. So maybe they're using in end-stage air hunger and maybe initial anxiety when the patient is fully aware and is gone to the hospital. That's where the benzodiazepine may be coming more into use. I haven't done that myself.
So based on what Moira and Dr. Param have just now said, I would modify my statement like this. If it is breathlessness and agitation, the sequence would be morphine plus careful benzodiazepine followed by haloperidol if necessary. If it is predominantly appears to be anxiety, midazolam as the primary measure, and in other contexts possibly haloperidol as the first line medicine.
Yes, sir. That's what we as a COVID group in Kerala, we had discussion over this, and then we had created these guidelines. Because in traditional cancer patients, delirious patients, there are, as you would know, there are umpteen causes for delirium, right from dyselectrolemia to sepsis or whatever cause that you can think of. And in that, we'll never try benzodiazepines first. We'll definitely go for haloperidol and antipsychotic first, and then later on benzodiazepines. So yes, we need to be careful in these patients and need to assess. So mind you, in COVID-19 patients, there is secondary bacterial infection imposed as well. So if there is any doubt, we can always go with haloperidol and then benzodiazepines. If you're doubtful, this is that or this, so you can always go in with haloperidol.
Okay, thank you. Any more points?
So I can see that, there's in the chat, there's some concern about QTC prolongation. But I think haloperidol, of course, it prolongs QTC. And in COVID patients, you're supposed to add on azithromycin and other drugs, which can again add on to the QTC prolongation. But I think on small doses, as we are talking about here, that shouldn't be a concern. The only problem is if older patients come and get admitted, and if they're on other medications that can, prolong QTC, or if they are having underlying cardiac problems, then it becomes a problem. But a 1-day dose of haloperidol probably is not going to cause that much of a problem. It's better to have them controlled rather than leaving them agitated and sort of violent in the ward. Ram Kumar has another comment. Dexmedetomidine, yes, Ram Kumar, but it's not easily available, and that's why I didn't put it here. So, for withdrawal symptoms, especially dexmedetomidine and clonidine acts on the same lines, and dexmedetomidine is very safe. We can give injections, but in patients like this, it's it's not easily accessible. So definitely in tertiary care centers, you could try that. And if nothing else works, I think in other countries, with a lot of caution, if it is like terminal delirium and things like that, we don't probably want to discuss that here. There are other drugs which people try, like phenobarbital. Doesn't like that drug too much, but in other countries there are other medicines available, like levomethomazine, which we don't have in India, which is so sedating and calms the patient down. We don't have access to that in our country. But haloperidol works well within our medical settings. What we found.
Dr. Biju?
Biju doesn't have. No, I think Dr. Murthy has a question.
Yes, sir.
Sir, we can't hear you, sir. Can you unmute and speak? Yes, sir. Yes, sir. We can hear you. You can speak.
Madam just said some drugs that are not available in India. She was talking about after haloperidol.
Oh, that is not available in India, sir. It's called levomethomazine, which is not available. Don't worry about it. So it's not available in India. It's
levomethomazine.
Yeah, it sedates people. It's a very highly sedative medication. It's an anti-emetic and sedative, which is used in.
Right. Thank you.
Sir, it's quite related to chlorpromazine. So it's an old-fashioned drug. It sometimes used to be called methotrexate. So it's an old-fashioned drug that is still used in palliative care in other settings. I was just asking Chitra if she could comment if we should use any of the newer antipsychotics if sedation is needed and haloperidol is not helpful.
We can use, I have seen a few guidelines. Thanks, Moira, sorry for asking me. The other antipsychotics which can be used are risperidone and quetiapine also. But like we are discussing, of course, we have to make it very clear, like Dr. Rajgopal mentioned, whether the agitation is because, if it is delirium only, we use antipsychotics. So, and we have to be be careful. But like earlier Dr. Param said, we cannot use much of the non-pharmacological measures that we recommend for delirium generally. And now that there are recommendations that even antipsychotics should be used with caution in delirium. It should be the non-pharmacological management which takes priority for mild to moderate delirium. But in COVID, I think we would not be able to use, because much of the nursing or the non-pharmacological measures will not be possible to carry out. The other antipsychotics which we can use are risperidone and quetiapine. But again, like in haloperidol, we have to take caution, like for the underlying cardiac status and everything. Quetiapine can be good. It's a good sedating drug. So, and it's quite safe also. Like for a mental health professional, I use quetiapine with no, kind of fear at all. But then in an ICU, again, because others are using it, it should be like monitored. So I think even haloperidol, risperidone and quetiapine can be used with caution and with monitoring. You would, being in intensive care, I think people will be monitored really well. And as of COVID and like the algorithms or guidelines we preferred haloperidol because we are actually looking at these guidelines for settings where you would not have many access to many medications, or it will be used by non-palliative care professionals. So to use with one which is more globally or universally accepted and used. I hope that answers your.
And we all know that haloperidol is not used in Parkinson's disease. So it becomes difficult. So we don't have other injections like quetiapine. If it is given, that's a drug of choice in Parkinson's disease, as we all know. It's difficult, and injectables are not available. So what do we do? Is a $1 million question. So Dr. Param, do you want to add on to that?
Yeah, it's just that we use a lot of quetiapine in our Parkinson's patients, as you said, because of the less extrapyramidal side effects. But even in delirium, there are evidence that quetiapine used in addition to haloperidol may actually have higher benefit. But that is more in the chronic delirium, people who go after the hospital into the home because delirium may persist. That is where the studies of quetiapine have shown. I'm not really sure if that is very much valid in cases of COVID, which is a hyperacute phenomena. So maybe haloperidol still remains the mainstay.
And levomipramazine, which Shobha mentioned, is again an antipsychotic. See, it's a low potency antipsychotic, which is not available in India. So it is again an antipsychotic. So another medication people use in psychiatry is Phenagan, promethazine, again, which is a neuroleptic, phenothiazine neuroleptics. So these are all medications which have more sedating quality rather than per se, the antipsychotic or the action against paranoia and delusions and agitation. So if sedation is preferred, you use drugs with more potency for sedation. So but I think for us haloperidol still holds true as the first drug that we should reach for, because you can doses and we can monitor well.
So is olanzapine available as injectables in India?
It is, but it is available only as long depot injections. Even risperidone and olanzapine, both are available only as long-acting injections. So we cannot use it for delirium. So haloperidol is and haloperidol as such, you can control it. So so I think I think haloperidol should be preferred. And I think the main thing is that you also use it with caution in the background of what comorbidities are there, and then monitor the person and check with a specialist if you're in doubt. And of course, if you think a benzodiazepine will benefit, you can add midazolam, like you said, Shobha. Like if haloperidol, if you are scared to go to a very high level, you can add small doses of lorazepam or add midazolam and see if the combination works.
Chitra, would there be a place ever for the melt version of olanzapine, particularly for families at home?
See, the thing with olanzapine is the risk of olanzapine causing thrombotic episodes are much. There are only anecdotal reports, but olanzapine we generally don't advise much for older patients and people with comorbidities, because there are reports that it causes thromboembolic episodes. So that is why we don't suggest olanzapine in such situations. Of course, we do use it as a last resort. When none of it works, we do use olanzapine because it is explained to the patient and the family and the patient, etc. So in this situation, if there is nothing else works and you have talked to the family, you are able to communicate with the family, we can use olanzapine melt, which can be dissolved and put it in the mouth. But I wouldn't recommend it as a first line or even a second line medication.
Okay, yeah. So now what I was thinking was in case the patient has got Parkinson's disease and we can't use haloperidol, so in that scenario, but then olanzapine melts, it's probably not available in every clinical setting. So then that becomes
quetiapine will be the choice there, Shobha, because you can go for higher doses also. Quetiapine has a good range of, you can go from 25 to you can go up to 200, 300 milligrams. So it's a very wide range.
Yeah, no, the thing is, if the patient becomes really agitated and you can't give tablets.
Oral drug, yeah. You can see, that is when you have to maybe use even Phenagan injection or whatever, like promethazine. If you don't have the long acting, the other antipsychotic you use in UK, but we have Phenagan injection, which we usually give as a combination with haloperidol.
Right.
So Seema, if you're online, please add to it. She's the other psychiatrist here. I mean, I can see her on the chat here.
Can a non-psychiatrist add something?
Yeah, yeah. Sorry, sir.
So,
I was asked to comment. I was asked to comment by Mara.
no. Oh, come on. I didn't mean it that way. Listen, if what happens when your conventional doses of these medicines, maybe haloperidol, midazolam, or whatever, benzodiazepine combinations, suppose they are inadequate. This happens often, and in intensive care units, the horror scenes that we see are those of patients tied hands and feet, physically restrained, which understandably worsens the agitation, and somebody hanging on to an endotracheal tube or a tracheostomy tube to prevent it being dislodged. And this is, I cannot imagine a more horrendous death. So maybe a couple of points need to be brought in. The first point is, the earlier delirium is treated, the less the agitation to follow. Yeah, delirium is easier to treat than agitation, but once delirium has gone on to agitation, understandably it becomes tougher. So physical restraint is uncivilized and torture. It has to be chemical restraint, and therefore we have to talk about rather high doses if necessary. Something that I never thought was possible, which I came to learn in palliative care, was the use of high doses of haloperidol. I understand that haloperidol, given parenterally, is much better tolerated than oral because the first pass metabolism is avoided. Therefore, metabolites which tend to cause side effects like rigidity are less, and therefore parenteral haloperidol is tolerated in higher doses, can possibly be tolerated tolerated orally. So one of the things that we do in people who are really agitated cannot be controlled by other means is to go up to as much as 20 milligrams in 24 hours. After sometimes we give incremental doses of till about 10 milligrams, and if that is not enough, we keep adding midazolam with no limits, as much as is needed to quieten the patient. Of course, there is the possibility that if it's a high dose opioid also in the system, the combination with a high dose benzodiazepine could cause respiratory depression. But here we are titrating it just to make the person quiet. So what am I saying? I'm saying that we should not be afraid of giving enough haloperidol up to 20 milligrams in 24 hours and with no ceiling on the maximum dose, bolus dose of midazolam, as much as necessary to quieten the patient. Would like very much like the comments of experienced clinicians in this matter.
Sunil sir?
Anybody would like to comment on what sir told now? Sir was talking about parenteral haloperidol, which would be better tolerated than oral route, and it can be given up to 20 milligram per 24 hours if needed, if the patient is really agitated, and chemical restraints would be better than the physical restraints. Yes, Bichu.
Uh, Agree with what sir was saying about chemical restraint versus physical restraint. I also agree with the doses. Only thing is that predominantly the COVID patients are going to be managed by non-palliative care doctor. It is a question of how comfortable they will ever be with the kind of doses we are talking about. I mean, it is absolutely a par for the course for palliative doctors, but may not be for the other doctors.
Dr. Chandni, I think your opinion will be very much necessary because generally it is to be expected that COVID patients are not going to be treated by a lot of palliative care doctors. Maybe there will be consultants available in some places, but that will be the exception rather than the rule. And we have possibly suggested things that may sound revolutionary in terms of dose, in terms of chemical restraint to the extent of making the patient deeply drowsy. If you have to treat in your ward a very agitated patient with COVID-19, how do you think you would like to go about it?
Dr. Chandri, your opinion regarding haloperidol in agitated patients?
Uh, I'm maybe being an old physician, I always used to prefer haloperidol, and but our younger generation is always with newer benzodiazepines. This is what is happening. And as Sir said, when Sir said it is better, I thought I was a bit happy, and it will be something I can tell my colleagues also, because we are more comfortable with this. That is why.
Yeah. So I don't know whether you have had that the dose of haloperidol can be increased up to 20 milligram if there is severe agitation. So have you had that?
Hello.
Hello, did you hear me?
Yeah, tell me.
No, sir was telling that if patient is severely agitated and sometimes patient may need higher amount of haloperidol up to 20 milligram per 24 hour. So do you, what is your comment on that?
I think I agree with Sir in that aspect, because agitation is something it's very difficult for us to treat even otherwise. So maybe we are monitoring and patient is with us only. So I think I agree with Sir in up titrating the dose.
Okay, thank you. So there is a question from Dr. Param about opioid analgesics in the setting of delirium, as these patients may have a lot of pain. Sir, would you like to take that question?
Sorry, I hope I have.
Yeah, I think someone has answered that question in the chat, so I'm good with that.
Am I audible now?
Yes, sir.
Let us underline thrice what Dr. Param has said, recognizing that pain is one of the commonest causes, untreated pain is one of the commonest causes of delirium. It's important to treat pain adequately. Now, here we have a paradoxical situation where a relative overdose of morphine also would cause delirium, the neurotoxicity of opioids. So it's a question of balance, and how we would try to achieve that balance is to err on the side of more opioid if necessary. If we suspect the patient is no longer able to explain, if we suspect, say for example, this was a person in pain already and could be in pain, we would still try to give the opioid and then add on other medicines. Now, I'll repeat what I said earlier. There is a possibility that a high dose of opioid plus a high dose of midazolam can cause respiratory depression. But then, fortunately, midazolam is reasonably short-acting and fast-acting and short-acting. therefore some degree of titration should be easier than it would be with a long-acting drug. So totally agree, Dr. Param. Thank you for making that point. If there is pain in a patient with delirium, pain needs to be addressed right away. Thank you.
Are there any more comments from anybody?
Moira has a
Sunil,
Yes.
just to remind people, there's very good algorithms being written. This ebook is going to be shared, so I think it's very good if you look at the agitation algorithm and the teaching alongside the breathlessness one that Raji presented so well yesterday, and then I think it'll help us out. So when we have breathlessness and agitation together, we combine those two algorithms. Of course, if it's only delirium, then we're looking at as we were talking about today with antipsychotics. So let's remember in COVID-19 end stage, it's usually that combination.
Okay, thank you. So, if there are no more questions, I think we can close this session. So, we were talking about agitation and delirium. So, Dr. SHOBA was mainly concentrating on agitation without delirium and agitation with delirium. So, in agitation without delirium, benzodiazepines alone might be useful, but in case of agitation along with delirium, then haloperidol has to be given, and the dose can be increased, and sometimes benzodiazepine also need to be added to that. And there are many causes which can contribute to delirium, including unrelieved pain. And we also need to think of withdrawal, especially we are hearing news about withdrawal, alcohol withdrawal in Kerala, and also withdrawal of opioids. All this can cause delirium, and the treatment will vary depending on the cause of delirium. Thank you, Dr. Shaba, for that wonderful session, and thank you all for your valuable comments. We'll see you tomorrow with the session on communication. Thank you all.
Thank you all for joining in. See you tomorrow. Bye.